Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We are grateful to have the opportunity to be and live in this territory. And on this Remembrance Day, we're grateful for all those serving and who have served. May we never forget their sacrifices for us. Today, we're delighted to bring you a new medication algorithm for individuals with fetal alcohol spectrum disorder. As mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well. And I will pose the questions to our speaker at the end of the session. Now I'd like to introduce our speaker, Dr. Mansfield Mela. Dr. Mela is a professor in the Department of Psychiatry at the University of Saskatchewan. He is an academic forensic psychiatrist, a founder of the forensic subspecialty in Canada, and also the current director of the Centre for Forensic Behavioral Science and Justice Studies. His research focuses on psycholegal aspects of forensic mental health with specific interests and expertise in the area of fetal alcohol spectrum disorder. It is my pleasure to pass the mic to Dr. Mela.
Thank you so much, and I'm very delighted to be part of your gathering on this very important day, Remembrance Day. As the topic theme showed, I'm going to be talking about a medication algorithm that I and a number of colleagues and international panel developed through a 4-year process. So even before starting, I just want to thank all the experts that I'll be referring to during this presentation for their hard work, their dedication. It was a long road, but we were very pleased to be able to share this with you. This presentation came about that after this article was published in the a journal recently. We felt it would be important for people to know about the guidelines to treating individuals with fetal alcohol spectrum disorder. So in the next 45 minutes, I hope to be able to provide you with some information about the reasons, especially from a pharmacological perspective, that individuals and children with FASD, for short, fetal alcohol spectrum disorder, do not always receive the adequate medical care that they need. I also hope to cover how the processes of developing the algorithm went about. So the why the algorithm, how the algorithm is, and what the algorithm exactly describes. I hope to cover that. And at the end, to just stress the relevance of this decision tree, and hopefully to allow people recognize that once you use it, there are benefits that accrue to the individual to improve their functioning, to the family to reduce the stress that they go through, and so society to have pro-social individuals in the community. As you will all know, for those of you who have been in this area for some time, FASD comprises a range of effects that, under the right nutritional and genetic situations, exposure to alcohol prenatally results in neurological, cognitive, behavioral, physical, and craniofacial abnormalities. FASD has a large burden on the health of society, and especially on the individual, because the trajectory of those who have been exposed includes adversity and poor and negative outcomes of life, ranging from poor educational attainment, lack of employability, homelessness, addiction, suicidality, legal difficulties, and generally a negative outcome. So treatment is very important. One of the methods of treatment is the use of medication, and that's what I'm going to focus on for the presentation. Why we decided to look at the issue of medication use in FASD, apart from the knowledge that FASD does not spare any organ, and so therefore there are medical conditions, infections, and chronic clinical situations that have to be taken care of, we recognize that the use of psychotropic medications had been reported in the literature, but there were a couple of sources that came to us. I work as a research lead with the Canada network of FASD research as one of the research leads. We were hearing a lot from family members, and I will tell you a little bit about what they were saying. But we also knew that there were concerns about how prescriptions were being given to individuals with FASD. For instance, we knew in the literature that children as young as 3 years were being given medication. We also knew that there was no specific indication for using medications in FASD. Almost all the use was off-label. And Dr. Osman Ipsiroglu had gone through his clinic and found out that out of almost 100 prescriptions of medications for individuals referred to his sleep clinic, on medications did not actually need them, and so there was really an overuse of medication. And almost in a counterintuitive way, Grauton reported that a lot of clinicians were hesitant to diagnose individuals with FASD on the basis that there was no effective treatment. So whereby there was a need to treat these individuals, the absence of that treatment was actually a barrier to diagnosis as well as access to care. The Canada Network for FASD Research has a committee that represents families. It's called the Family Advisory Committee. They are obviously very close to those individuals diagnosed with FASD and live the life with them. And so they came forward to the research leads with certain concerns of what they were hearing from their members. Some of these included the lack of information for clinicians on how they use medications, the lack of information on how those medications work, as well as the fact that many of the individuals living with FASD were being given medications in large quantities and large doses. The families told us that the individuals taking medications were having a lot of side effects, and when they brought this up to the doctors prescribing, they judged that those prescribers did not have any good knowledge of FASD and therefore were very concerned about the prescription. So those are some of the things that started to come to us. As a research group, we had looked at what was written in the literature about the use of psychotropic medications in FASD. And one of the things that struck us was the fact that while this is common knowledge, when you see 10 individuals with FASD, you have essentially seen 10 individuals. So there was a wide variation in the neurocognitive deficits that all individuals had, and so it was very difficult to align the treatment to just neurocognitive deficit. That was a common pathway for those with FASD. There was a lot of misdiagnosis as well as multiple comorbid conditions that people with FASD have, and so trying to decipher what medications were prescribed for what conditions was very difficult within the literature. There was also, unfortunately, a very slow pace at the development of evidence. And I'll tell you a story about atomoxetine, one of the medications that has been researched in FASD. One thing that we thought may be a potential reason was also the amount of stigma that came along with FASD may have been obstructionist to the process of developing guidelines for treatment. So overall, in a systematic review that my team was able to complete in 2018, we were able to gather that in all the literature from about 1998 in terms of what medications have been used in people with FASD, the following were probably the conclusions. The number of participants were very small. In fact, I would tell you that in the whole of the literature, there were not more than 350 individuals that were treated with medications with FASD and studied and reported. And that the range of medications that were being studied were very few. As well, there was a tendency to focus the studies on those who presented with purely ADHD type presentation, which, by the way, is very frequent in people with FASD. There was a sense that those who were treated with medications tended to react with side effects in a slightly higher proportional rate than those without FASD. What was more disappointing was that all the available research could provide no particular guidance because there was poor ability to calculate the power or the effect of the treatment, and all the treatments that were applied to those with ADHD produced no effect on inattention. And so really, apart from a few case series that we could say supported the use of those medications, a lot of the treatments may have been settled on a trial and error basis. As mentioned earlier, there's been a little bit of a waiting for evidence. The clinicaltrials.gov is the website where you find all clinical trials registered. And there was a clinical trial of atomoxetine in 2007, and up to the point of our systematic review, that trial had not finished recruitment. So there was a long wait and nothing was really moving on in terms of the medication. All is not bad in that, as I mentioned, in our systematic review, we did find some advice related to symptoms of ADHD, which was a focus in a number of the studies. There was some evidence in terms of non-psychotropic pharmacotherapy, such as choline supplementation. And there was suggestion that subsequently, given the psychosocial treatment of self-regulation, there may be some interventions that could lead to pharmacological use. So all this to say that we advance that we may have to look at things differently. And so we called a panel of experts. This is actually a picture of all the experts except one who met in 2016, October, to begin to deliberate on how we can move forward to help clinicians and, of course, our individuals who have FASD. It was a broad range of specialization. There was a family physician, pediatrician, neurodevelopmental physician, psychiatrist, sleep specialist. And I think two of the members that I'm more excited about when I talk about this is that we had a family advisory committee member, so giving us the perspective of the family. And we also had an algorithm expert who knew nothing about FASD. So it was quite a rigorous process, and we thought developing an algorithm was very important because we saw it as a way of getting better outcomes, because we were going to focus the development on what was currently evidenced and what was currently practiced. We also knew that because of the difficulties of getting treatments, we thought a stepwise approach that is systematic and could be examined by others was the way to go. One of the goals was to respond to the concerns that we had from families, especially that of polypharmacy. And we thought that by developing a stepwise approach, we will minimize the risk of adding medications to people who are responding or reacting more negatively to it. And indeed, in the field, because there was no specific guide for clinicians and non-clinicians, this would be the beginning of a process that people would use for treatment. And more importantly, as I mentioned, because it was going to adopt a research approach, it will be evaluated and updated and probably improved over time. And this is one of the reasons why I think this presentation today is important, because we recognize the limited amount of information we use to develop the algorithm, but also understand that to perfect it and refine it will require gathering information on the use of the current algorithm, which will then be able to help us set the stage for advancing and improving the algorithm. We knew that algorithms have been used successfully and effectively in other areas of psychiatric and medical diagnosis, and so we thought we would be on the right path. The process is probably not necessary for this audience, but this is just a summary of it, whereby experts who were very knowledgeable in the area, who ran clinics with people with FASD, were brought together from their perspective. We had a summary of all the information in the literature as far as we knew from 1998 to 2017 that was published about individuals who were treated with psychotropic medications. We brought that evidence before the experts so that they can collaborate and compare with their own practice. This then resulted into the initial draft of an algorithm, which was subsequently refined by the experts based on what we knew was available in the literature and what they were using. As you can all imagine, people practice differently, and so to get consensus wasn't an easy thing, but we were able to produce one, which I'm going to share with you. And at the present time, at the right part of the slide, as you can see, we are now in implementation and evaluation. We deliberately add evaluation to encourage all those who will use the algorithm to report back to us on the usefulness, the utility, and the effectiveness, or even the negative aspect of using the algorithm. So in summary, the why, the how, and the what. Why did we develop an algorithm? Well, as I mentioned, the Family Advisory Committee shared their concerns about their family members who were being treated with medication. We were aware that from the literature and from the accounts, there was likely overprescription. There was a tendency towards a lot of consequences of adverse effects, including very idiosyncratic reactions to medication. At the time, there was no guidelines, so we thought that was a good reason. And we knew that decision tree and algorithms have been used in other disorders. And one of the greatest reasons really is that we would like our individuals to have functioning status that was compatible with living in a society whereby they feel they are contributing, and which is the goal of our treatment. So what exactly does the algorithm constitute? It allows the clinician to go through some steps that will gather information, deduce some right decision, and be able to make a decision. As well, it encourages the fulfillment of all the non-pharmacological strategies. This will include the enhancement of environmental and psychosocial support for the individual, supporting the individual's good sleep, nutrition, and hygiene, and then advancing the treatment by recognizing treatable clusters, and I'll describe those for you in a minute. We encourage the clinician through this algorithm to take a step-by-step approach at prescribing and introducing one medication at a time. And the algorithm seeks very deliberate feedback to ensure that the patient benefits from such treatment. The clinician recognizes also an easy step of treatment and be able to add to the refinement of the algorithm. So this is exactly what the 4 clusters look like. So after much discussion, review of the literature, trying to understand how closely related to the neurological deficits this could be, the experts panel chose these 4 domains. So going from your left to right means that once an individual has already been diagnosed with FASD, that one or more of these domains will be likely to be impairing their functions. So the hyperarousal functioning would be for an individual who manifests chronic fear. Examples of tension, temper problems, agitation would be a couple which seem to relate to abnormalities in the brainstem, midbrain, and limbic system. The second domain or cluster is the emotional regulation, whereby mood changes of all forms will be considered, including mood, depression, and excitability. For this, the experts believe that the origin of such confluence of symptoms will be the hippocampal damage and amygdala damage that we know are related to FASD. The third cluster is that of the hyperactive and cognitive domain, and this is usually related to the frontal lobe as well as the brainstem. And in this regard, we see a situation whereby an individual is either overactive, procrastinates, examples of risk-taking behavior, lack of maturity, or dysmaturity, as we see in a number of individuals. The last domain is that of cognitive inflexibility, located most likely to the damage related to the dorsolateral orbitofrontal cortex, and this is where there's a lot of perseveration, destructive tendencies, inflexibility, and lack of initiative to strategize solutions. As you can imagine, that dividing these domains is not as pure as we would like it to be, but given that the individuals already have multiple neurocognitive deficits, it was necessary to try and identify what in the literature has been used to treat individuals with these domains. And so this is how we came about with the medication algorithm, which looks like this. And near the end, there will be an email address whereby if you will request, we will send you a copy of the algorithm and other materials that will be helpful in understanding the guidelines as well as providing access to the evaluation that we are hoping to complete. So the algorithm as it stands will be dividing the clusters in line with the medications that we propose as an expert will be the first line and the second line. And I will also share with you how the step-by-step approach will look like. So in the case of an individual who already has been diagnosed with FASD and manifesting the hypercognitive neurocognitive cluster, which is the third from your left, what we would instruct the clinician to do is first ensure that all the non-psychotropic interventions are fully in place and the dysfunction or impaired function still exists. And some of those interventions, as you will all appreciate, very relevant in people with FASD are the not only reducing impulsivity, improving function, but these are things that are necessary for brain development and plasticity. So the sleep function, adequate nutrition, and exercise. Once those are put in place, whether it's accommodation in class, accommodation at work, and parental treatment, and all the psychological strategies, we then advance that the continuing impairment of function can then be treated by the first line medication, which in this case is an amphetamine-based stimulant, such as lisdexamfetamine or dexedrine. If that treatment produces benefits, then the person continues with it. If there is another cluster, for instance, an hyperarousal cluster, then consideration for then additional medications will then include the first line medication, which is either clonidine or guanfacine. Now, we also recognize that there are times whereby once one cluster has been handled adequately, that there may not be any need to treat other clusters, and what is the advantage of trying to use a decision tree to prevent polypharmacy. We also recognize as well that there may be times whereby the 2 or 3 or 4 clusters may be in existence. We advise the clinicians through the article I showed that the most function impairing cluster should be targeted first. So a student in class who is emotionally labile but also inattentive may still be inattentive, but the emotional ability may make the person's status in class to be in jeopardy, and therefore that may attract initial treatment before the inattention is dealt with. So that's how the algorithm is. We also recognize that there are situations whereby people on the expert panel told us of things that they've tried before, things that may not have been in the literature. We did not want to include those. We wanted to include what was currently available as evidence, but we do know that over time, there may be other things that are being tried. So that's why we included the adjunct component. As well, we know that there are existing algorithms in other areas. So, for example, if someone with FASD is manifesting a lot of the ADHD symptoms, there are algorithms that exist. If the person has anxiety, there are algorithms that exist, and those guidelines can be used to treat the person. So, this is how the algorithm works. We definitely stress the importance of assessing what the baseline function of the individual is, focus the goal to changing that level of functioning so that the person is fully functional, choosing the most functioning impairing cluster to treat, as I mentioned. When medications are used with people with FASD, we suggest that we start low and go slow, and this is usual advice that we know in neurodevelopmental disorders anyway. We also encourage that the dose change should be dependent on risk-benefit ratio, not maximum benefit levels. Most treatments are to achieve a certain level, but in FASD, we suggest and stress significantly the need to monitor side effects and see if the benefits outweigh the risk and continue with that, but also to recognize that increasing the dose should be guided by this risk-benefit ratio rather than the desire to achieve a optimum level of medication. We incorporated the importance of evaluation that I'll talk to you about in a minute, because we strongly suggest that this algorithm will be useful, but it would be better used if we could advance it in a more appropriate way. So for the step-by-step approach, this is essentially the guide that a clinician can have or could potentially be included in an electronic medical record. We're still working on how to do this, and we've got some feedback that I'll share with you. So essentially what this allows is that to go through the steps, an individual would have a confirmed FASD diagnosis. Then there will be the establishment of the functional baseline. Certain goals will then be set around function, because that's all we are trying to do, is to improve the function of the person. Yes, decreasing the behavioral abnormalities, but to improve function in a more positive way is what we envision. Then the clinician and the individual will determine what are the clusters that impair function, and out of those four, one of those clusters will be chosen as the most impairing. The clinician will ensure, and the family as well as the individual, that non-psychotropic interventions are optimized, and then starting the first line treatment based on the algorithm to target that cluster that is impairing functioning. Once that treatment has been started, we again advise that the medication should be introduced at a low level and then increasing over a protracted period of time. We recommend between 2 to 6 weeks of trials, whereby the risk-benefit ratio will be estimated and the side effect allows for increase in medication. Indeed, towards your right-hand side, if progress is observed, that medication should be continued with and then increase appropriately based on the risk-benefit ratio to improve the functioning. If, however, there is no progress, there is a potential that either moving to the second line of treatment will be more effective in the same process, or treating the next target causing the difficulties. We also recognize that the next line of treatment based on existing algorithms is what we advise in the article. And then lastly, in the section of our article that we wrote, there is an adjunct section where individuals on the panel have tried various things that we think could be considered by the clinician in discussion with the family and the individual who is being treated. So those are how the algorithm works, but we also know, and we advise through the article again, about some of the important factors to consider in making prescribing acceptable and enhancing its utility. There are pre-treatment factors that individuals with FASD need to be assessed about: their previous experience with treatment, their stigmatization by the system, and some of the things that could interfere with the therapeutic working alliance. For the clinician willing to help an individual working with goals that were collaboratively set, as well as maintaining a positive working relationship, and encouragement cannot be overemphasized in trying to maintain compliance with the medication. There is importance to monitor some of the boundaries regarding medication use, whether it's abuse, diversion, and all of those. We gave some sections to advise clinicians on what to do. We conceptualize the use of medication as one of the supportive strategies for the individual. A psychological strategy exists, a social strategy exists, accommodation strategy exists, and a pharmacological strategy is what we are adding to this. So the clinician needs to be aware of that. Stabilizing an individual's environment is crucial, or else the role of the medication will be overwhelmed by social factors such as homelessness, substance use, and poverty. And so the clinician in this regard has to consider the other stabilizing factors for their patients. We also recognize that engagement of significant others is crucial to this process. Given the cognitive deficits of an individual with FASD, there is a need for caregivers to be on board from an educated perspective, but also in a supportive role. Frontline staff can do a lot of work in terms of using technology to remind individuals about taking their medication. The pharmacists themselves have a very significant role in supporting an individual, whether reminding them, simplifying the process of administration, and in the language that the individual can understand. Even teachers in school who are able to, with the right confidentiality, take an active role in supporting an individual, and many other allied professionals should be considered, because this is a process whereby there is a narrow window of safety sometimes in certain individuals, and therefore we need everybody on board to provide the right conducive atmosphere for prescribing. We've already started to receive some feedback, and I thought I would share those with you. One of the feedback about it was that we did not specify the doses of medications, and that was deliberately done. We don't know whether we will specify this in the next iteration of the algorithm, because, as you can imagine, we are emphasizing the need to use the dosing of medication according to the risk-benefit ratio. So to specify a dose may be challenging. We may be able to do a per kilogram weight dosing. One matter that has come up, and even within the experts, is the use of medication in children. We advise that children below the age of 7 should not be treated with psychotropic medications, but we also do know that there are all forms of studies that have looked at the use of probably more dangerous medications in children. We've not yet adopted it in FASD. We would have to look into that in the next iteration. What is the right age, and how do you monitor it? When is it effective? So there are a couple of questions for younger children. The position, or rather the status of the clusters, is still one that has some biological foundation and backing, but not as purely as people would like to have it. We were just fortunate to be able to narrow down the almost 10 different brain domains that have been associated as deficient in people with FASD to clusters that are 4 that have some potential pharmacokinetic basis for treatment, pharmacodynamic. The other thing that has come up as a feedback is the possibility of using our algorithm and the step-by-step in an app form. This obviously we would love to do when we have a refined iteration that we now know is being backed with some reasonable amount of data. Inclusion of the algorithm in an electronic medical records and the billing code for it would also have to follow similar conversations around the need to get it better refined from this level of evidence before we can proceed to institutionalize it. There were some suggestions in terms of who exactly does this algorithm address. We want it to be used for those with FASD that have 1 or 4 of those clusters. We have to take care of child-specific issues like dosing, side effects, and the lack of access or contact with any psychotropic medications before. Our goal is obviously in the next 2 to 5 years to implement, evaluate, and come up with a refined algorithm. And we really need the data on that. So one of the things I will encourage for you, whether working directly or indirectly in this area, to consider reaching out to us to receive the package for the evaluation, as well as to share your experiences with us. So these are, if you're going to help us with the evaluation, these are just some of the questions that are available on the online surveys that usually takes, I believe, about 10 to 12 minutes, maximum maybe 15 minutes. Our goal is to try and ensure that individuals using it can respond to guide us in terms of what exactly the treatments that they were advocating for the patient and what other comorbid conditions are present, so that we know whether the medicines are working as well as we thought they will. In terms of the range of medications that we have included, this is essentially almost everything that is on it. So it is based on the algorithm, what was prescribed. Of course, here it says, I prescribe the following medication, essentially pointing to the fact that the clinician will prescribe, but also we believe that the individual with FASD and their family can ask the physician to help them, I guess, monitor the benefits of the algorithm if the person was using it. We've listed a couple of side effects that the clinician will endorse if they're present, so that we can know if the medications we are using in the algorithm is causing that. And lastly, again, this is a 15-minute survey, so I'm just giving you a sample of those questions, and the doses that was used, will be willing to look at it and analyze at the end. And what was the outcome? Was there any benefit? The benefit minimal or substantial? And we hope that at the end of the day, the patients, their family, and the physician will be able to say whether this algorithm was function improving, or easy to use, or both. We would love to be able to know how to refine this further. So in concluding, I just want to say that indeed children with FASD commonly have a variety of behavioral disorders and difficulties. Comorbidity is the norm rather than the exception. We believe that treatment should seek to understand the multifactorial contributions that come from various areas like behavioral, sensory, and pharmacological strategies, which will then help in terms of deciphering what treatment goals should be and target. We have described how the algorithm was developed and also explained to you how to use it. And we believe that such decision making has a lot of advantages and will benefit our patients to be more functional, as well as to avoid some of the risks and benefits that we learned from the literature and from our families about what medications have done in the past. We believe finally that getting feedback, if we wait for randomized controlled trials, as we've been waiting since 2007 in the case of atomoxetine, we may never get to the right advice. So this is one way of trying to get to a sound, reasonable, and function improving advice. And so value all those who will be willing to provide feedback on their experience with the algorithm, and indeed what it has done for functioning, and to help us refine the algorithm in the future. So I want to thank you very much. I have a lot of partners to thank for some of the work that has been going on since 2016. And there's an email, as I said, we have the article is public access. We have the algorithm available on this email. We also have the step-by-step approach and access to the surveys that we can definitely be able to use. So I'll stop there, and I believe we have time for some questions. Thank you.
We do. Thank you very much for that great presentation. We have a number of questions in the queue, so I'll just get started. Geeta has asked, can you tell us a bit more about the colon supplementation? What's the mechanism of action, the dose, the symptom target?
Okay, so can you hear me?
Yes.
Okay, thank you. Yeah, so choline is one of the areas that has excited a lot of people. Right now, the latest evidence was actually an article that was published by a group that followed a 4-year sample after treating individuals divided in 2 groups, one with placebo and one with choline. So the mechanism of action is that it is one of those amino acids that help focus, is a precursor to acetylcholine. As you know, acetylcholine is a very useful neurotransmitter when it comes to cognition and memory. And so choline is the precursor to that. It is helpful in brain development and especially cognition. It has been found in animals to assist in the development of the hippocampus and for dendritic arborization. So the what you need for plasticity, what you need for connection between the neurons and the micro neurons. It is also been found to be effective in the hippocampal cholinergic system. So most of the studies started initially for prenatal supplementation, essentially giving mothers who are pregnant, and there's been at least 4 different studies around it. The doses are still being determined. They range from around 500 milligrams and sometimes up to 1,000. Some studies that seem to suggest that you need higher doses, that some say that you just need the average doses that we give people. So I think the doses are being established. As you can imagine, we do not yet have a Health Canada approval yet to use it. As I said, we just had the randomized control trial. We need more evidence to get it to the point whereby it's approved for clinical use. We're still just gathering enough data. There were unfortunately some negative results suggesting that they only work in younger children between the ages of 2 and 3. But this last study seems to give a little bit of hope in that what it did in many patients was that we found, comparing those on clonidine and on choline and those without, that there was improvement in memory, attention, but not in executive function. So there is a while to go before we can bring it into clinical use. I hope that is helpful.
Thank you. Melissa asked a question that I think was at least partially answered through your presentation about any equivalent studies for children and youth, and how would the decision tree perhaps be adapted for the peds population? But I think you've answered that, unless you would like to clarify further.
Well, the clarification really is the fact that children are so unique when it comes to the use of medication, and there needs to be some reasonable safeguards and strategies that can help, especially younger children. Interestingly, most of the research that was done looking at the use of medication was actually among children. And so it is one of these binds that we find ourselves whereby, yes, the studies were about children, but then for us to actually sanction it for the use of children specifically, we need a little bit of more guidelines and strategies. So I believe once a clinician sees this algorithm, if they're interested in further information, actually we have a number of our experts. As I said, we had at least 3 to 4 pediatricians as well as developmental pediatricians who can answer more questions on that.
Thank you. Lynn has asked, is it possible to have a mix of symptoms from each cluster?
Yes, Lynn, and I've worked in the area for some time to set the stage. When you do, remember that these clusters in our minds arise from the cognitive deficits that arise from the damage that the prenatal alcohol causes to the brain. So if you just go backwards and look at the damage and how much cognitive deficits exist. So we have language problems, we have memory problems, we have executive function, we have academic problems, we have attention problems. So there are many, many domains, to the extent that the Canadian guidelines recognize 10 domains that could be impaired. So in most studies of individuals with FASD, you find out that the average number of impaired domains, now not clusters for the algorithm, but domains for neurocognitive, is somewhere around 4 or 5. So there's a lot of abnormalities that exist there already. We've done studies, especially in adults and offenders who have had negative outcomes, and they're getting 6 to sometimes 8 different domains that are impaired. So unfortunately, a number of individuals exposed to prenatal alcohol are significantly impaired in their functioning. So it is not surprising that you will find an individual who is having hyperarousal problems, hyperactive problems, and cognitive inflexibility. Consider, for one, the 11-year-old who has a particular way of arranging things in their house. They would not give in if you try to change it. They become very upset easily when you make a sound, or if something scares them, and become very emotionally deregulated. They also are very hyperactive in class and cannot pay attention. Already you can see virtually 3 or 4 of the domains of the clusters for the medication have been included. We recognize that, and that's why the advice is choose the cluster that is most impairing. Address that first before going to the next one. So yes, a long way of answering the fact that we are going to have to see individuals who do not have a clear case whereby you are very clear this is the only cluster that is present. You have to deal with the multi clusters that are going to be present in individuals.
Thank you. Elsa has asked, could you clarify why dexedrine is first line and methylphenidate is second line for children with FASD presenting with ADHD features?
Thank you. Again, the experts actually went to and fro on that. Most of us recognize that we almost always went for methylphenidate as our first line. But what we found, remember, it was a combination between our practices and what was already published in the literature to try and get the practice evidence balance. And what we found was that a number of the research, specifically 3, which included 2 randomized controlled trials and a case study that I referenced in my presentation, did find out that actually the amphetamine products seem to be a little bit more effective in FASD. There are a couple of evidences that we can use. So for example, there was an animal study that looked at what areas were damaged by alcohol, and they found out that the frontal lobe D1 receptors versus D4 receptors versus D1 receptors were more impaired. There were studies that looked at in children whereby they were all treated with methylphenidate, and only 32% of them responded. And out of the remaining 68%, when they were treated with amphetamines, close to 80% of those responded. So based on those factors, we felt that at the present time, with the evidence that we had in the literature and our practice, we elected to put the amphetamine salts, dexedrine and lisdexamphetamine as the first line before the second. Just on an aside, I was actually blessed to have one of our most prolific FASD treating physicians in Saskatchewan allow us to evaluate her clinic over the years, and we were very pleased to see how well the algorithm was doing, but also to recognize that even though we are choosing the dexedrine, there are unfortunately some provincial pharmacy rules that may prevent that. So, for instance, some provinces will insist that methylphenidate is available, but if you want to try to use the dexamphetamine, then you have to get a special permission. So we recognize that, but unfortunately, what we have in the literature and what we can advance at the present time is dexedrine first.
Thank you. Jackie has asked, what do you recommend doing to address the problems that people with FASD may have in measuring their own internal states? She says they generally need help self-evaluating, especially with adults where the doctor might expect them to know whether they feel better now as opposed to before.
Thank you, Jackie. That's a very excellent question, because if we're trying to evaluate the algorithm, we need as objective as possible data on whether the algorithm is working or not. Now, in recognition of that, one of the things that we're working on with families is the appropriate approach to physicians. And I'll just take a little bit of a side tour here to say that there are no physicians that we know that desire to make an individual malfunction. I think all physicians are trying their best to help their patients. They're doing all that they can based on what they know. And I use myself as an example. I've practiced for 14 good years before I came to know anything called FASD. And so if you came to me and said, no, this is what you want me to do, I'm going to get irritated because I didn't know what FASD was. So our approach to physicians is very crucial. And so part of your question, Jackie, is the fact that we know to gather the right information, you need a physician that will be willing to go the extra mile of not only just asking, how are you feeling? Tell me what is going on, but to actually go beyond that to find the meaning of what the person is saying. Remember that not only is the self-monitoring an issue for those with FASD, but also expressing it is an issue. So just telling you that things are going well doesn't mean anything, or I may not have even had the question well. So there is a bit of work that needs to be done in the context of trying to get the physicians to seek out the right information. There is a need to reach out to collateral information through those who care for the individual and frontline staff. That's why you heard me in my presentation saying prescribing alone is not enough, but engaging frontline staff, family members, the pharmacists, caseworkers, all those are important. Now, that is not to say that individuals with FASD cannot tell you how they're feeling between one situation to the other. There are tools that can be used to help them monitor that, but there's also the need to depend on collateral information. So all this to say that the central person, I believe, will be the physician who is going to be reaching out to be able to get the objective monitoring features, as well as caseworkers and those who work with the individual with FASD to try and support them in gathering that information. By the way, there are ongoing studies now on self-regulation, that individuals with FASD can be taught how to self-regulate. So we know that we can teach them to self-monitor and self-regulate. Yes, it may take longer than those without the cognitive deficit, but it is doable.
Thank you. We have one last question that we'll address now, and I'll encourage our attendees to contact Andrea, and her email is in the chat box if you have additional questions that you would like answered. But for the last question that we'll take today, in your interim research, have you found positive functional effects from atomoxetine?
That's a tricky question. Unfortunately, I have not. I had always hoped that they will finish that study and maybe we can. So just on a personal basis, I've tried both in FASD and in ADHD. I've not yet found that significant benefit from it. So that's not to say, I mean, it has an indication for treatment. And as I said, there is this ongoing research happening. We have included it as part of our second line treatments, including Wellbutrin, because there is some evidence in the literature of people using it. So don't use my experience. I treat older patients and those in trouble with the law, so you can't use that as an example to conclude on the whole of FASD.
Thank you so much, Dr. Mela, for sharing your time and expertise with us today. And that's the end of our time together. I want to thank all of our members and other attendees for spending this time with us, and we hope you depart with some practical knowledge to bring back to your organizations. We have a packed fall Spark calendar schedule still continuing. Join us next week for our annual conference taking place virtually on November 16th to 20th. And to register, visit our website at childrenshealthcarecanada.ca. And then the following week, on Wednesday, November 25th at 11 a.m. Eastern, we're pleased to partner with the Child Bright Network to bring you Conducting a Research Trial During a Pandemic, the New Normal. It's always great if you can watch live, as your questions and comments enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thank you to Dr. Mela for this presentation, and hopefully we'll see many of you at our conference next week. Bye, everyone.